I'd like to welcome everybody to another BATS webinar, this time on the management of renal hyperparathyroidism. I'd just like to thank all our speakers for spending time with us on this rather beautiful evening to give us their views on surgical renal hyperparathyroidism. I'd like to just also thank Sid, who does such an enormous amount of work for the BATS, setting up all these webinars. And again, what a wonderful title. And we look forward to it today. So I'll just hand over to Sid and welcome.
Yep, great. Thanks, Alison. So we've got a variety of speakers today. So as you can see the timetable there, we're going to start off with Seb Aspinall, who's an endocrine surgeon from Aberdeen, talking about UK RECTs and renal parathyroid surgery and what that tells us, what's been going on in the UK in the last 20 years or so. So I'm just going to stop sharing there. Seb, I'll hand over to you.
You got it?
Yeah, let's good.
Yeah, good. Okay. So yeah, I did this work 3 years ago with Amy Campbell. She's a ENT registrar who was with me at the time. Right. Now we can't. Yeah. Okay. I'll let Martin talk about what the indications for parathyroidectomy are, but we'll come on to that. There's a lack of evidence at the time, 3 years ago, on how many glands we should be removing at surgery and whether localization techniques are useful. So that's why we analyzed the Bates database. And the aims were, pretty straightforward. We looked at first-time parathyroidectomy, and we wanted to establish risk factors for adverse outcomes. And they were those temporary hypercalcemia, persistent disease reoperation, etc. And I'm sure that you're all aware of the data points that we put in the national database on parathyroidectomy. Apologies for those who aren't, but there's quite a lot of data there to take in. But the main point is that there's one question with 5 stems for renal disease, and that's, is the patient normocalcemic, hypercalcemic? Is a medical treatment alone dialysis or post-transplant? And the problem with that data point is that it's not compulsory. So when we looked at the data, there were some cases where all 5 boxes were ticked, and that doesn't really make sense. So really, we've got to rationalize that in the future. We've got to make 3 stems, i.e. they're either normocalcemic or hypercalcemic, and that's a compulsory thing, because otherwise we don't know what type of parathyroidism they have. If they've got medical treatment alone, I think presumably they've got primary hyperparathyroidism with chronic renal failure. But I mean, I'm not quite sure. And the 3rd stem, they should be either on dialysis post-transplant, or they can be post-transplant and dialysis if the transplants fail. But the lack of clarity on that one question created a lot of problems in the analysis. So we looked at 20 years of data. We excluded the extremes of age, anybody who stayed in hospital for over a month, because there were probably data entry errors. And we divided them into transplant dialysis groups. And then we looked at different types of operation, total, subtotal, less than subtotal. And then we did a multivariable analysis. We excluded any variables that were significantly correlated in a multivariable analysis. So I think it's Pearson's correlation coefficient over 0.5. And so we looked at the entire cohort, and then we looked at total versus subtotal. So this is where another of the problems that comes in. Well, first of all, we talked about secondary hyperparathyroidism as being normocalcemic patients and tertiary hyperparathyroidism as being hypercalcemic patients. And we analyzed the ones that had had a transplant and dialysis in the dialysis group. So that's fairly straightforward. But the first criticism we had from reviewers of the paper when we tried to get it published were that our definition of subtotal parathyroidectomy was old-fashioned. We have in UK Rets 3.5 glands is a subtotal, and I mean I don't think we actually remove 3.5 glands as such. We identify 4 or strive to, and then we remove 3, and then we remove enough of the 4th to leave a normal size remnant of parathyroid for the long term. And I think that roughly equates to 3.5, but it's not exactly 3.5. And I guess when you come to try and publish papers like this, that the reviewers pick up on that sort of thing. The second definition, post-operative hypocalcemia, is great for primary hyperparathyroidism, and I struggle a bit with renal patients as to what to make of it when we've got a patient on dialysis and things like that, and my simple surgical mind struggles to understand the actual relevance of the temporary hypercalcemia in that setting. The biggest problem we had in the data analysis was persistent disease, because in UK Rets, persistent disease is defined as hypercalcemia persisting at post-operative follow-up, which is a reasonably good definition for primary hyperparathyroidism, but not really very good for normocalcemic primary hyperparathyroidism. But for renal hyperparathyroidism, it's pretty bad, because if you imagine that those guys with secondary hyperparathyroidism, even if you took them to theatre and opened the neck and didn't remove any parathyroid glands, there would still be normocalcemic post-operatively. So you would, it doesn't really identify failed explorations at all. The other outcomes are fairly straightforward. Now, looking at the number of operations we do, 127 median per year, so not many. An awful lot of surgeons have evolved over the last 20 years, 120, and we're doing median 1 to 2 operations a year. So there's a bit of an issue there about volume outcome, maybe case volumes being very low. Whether that affects outcomes, we didn't look at. Missing data is a big problem in UK Rets, and one of the reviewers, we picked up on the fact that if we cross a threshold of about 40% missing data, then it introduces so much bias that our conclusions then become difficult to justify. Anyhow, we had about a third of cases were excluded because of missing data. Sorry, this slide is a bit busy, but I just wanted to show the problem with persistent disease, because the proportion of cases with secondary hyperparathyroidism in each group, so in each per operation, and whether dialysis and transplant, etc., affects the persistent disease rate. So the patients with having a total parathyroidectomy, they've got a higher incidence of secondary hyperparathyroidism, and so their incidence of persistent disease, will be more underestimated than groups that have a lower incidence of secondary hyperparathyroidism. There's part of me that felt we should just ignore persistent disease altogether, because of the inaccuracies it brings in. And we're on I'm presenting the second run through of this, the second analysis, and we're inevitably going to have to do a third analysis if we want it published. So there was a higher incidence of secondary hyperparathyroidism in patients who had a total parathyroidectomy, those who had dialysis, and those who didn't have imaging. But overall, pretty much an equal number had secondary and tertiary hyperparathyroidism. And then we've got a group about 22% where we don't know whether they're secondary, tertiary, or primary hyperparathyroidism with chronic renal failure, and that introduces further uncertainty. So bearing in mind there's quite a big pinch of salt that we have to take when we're looking at persistent disease, you can see that unless you remove 3.5 glands, the incidence of persistent disease is pretty high. In fact, if you remove 3 glands, it's highest, 9.3%, 9.13%. And whether that is because if you remove 3 glands, you fail to find the 4th, I'm not sure. I wouldn't usually remove 3 glands. I think normally in renal hyperparathyroidism, all 4 glands are enlarged and they're pretty big. So you wouldn't leave 1 gland behind. It might be in some instances, the 4th gland is normal size and you leave it behind, but it seems unlikely. The incidence of temporary hypercalcemia is high, nearly 50%, and it obviously falls with, lesser parathyroid resections. We did a multivariable analysis. So the incidence of persistent disease was 3.5% overall. If you have a total parathyroidectomy, it's reduced. If you have a less than subtotal, it's significantly increased. So 8.3% for less than subtotal parathyroidectomy. And if you think that's actually an underestimate, because a small proportion, about a fifth of those, will have secondary hyperparathyroidism, that is quite a high incidence. And, if you have a total parathyroidectomy, you're more likely to have temporary hypercalcemia. If you have a less than subtotal, you're less likely to have temporary hypercalcemia. That's logical. Post-operative complications are a bit higher in the total parathyroidectomy group. Reoperation for bleeding didn't seem to vary between groups. Length of stay was higher in the total parathyroidectomy group and lower in the less than subtotal group, but then you'd probably expect that, because more of those will be having dialysis, so they would probably have dialysis post-operatively, and that will probably increase their length of stay. What about what sort of type of surgery are we doing? So we're doing total parathyroidectomy more in the dialysis group, and we're doing less than subtotal less in this group. In the transplant group, we are doing total parathyroidectomy less, and subtotal or less than subtotal more frequently. If we look at the overall cohort, persistent disease seems to be lower in the transplant group. You can look at the results. Temporary hypercalcemia is higher in the dialysis group and lower in the transplant group. Understandably, because you're doing more bigger resections in the dialysis group. And we talked about length of stay. So what factors are affecting having adverse outcomes? Well, we have some caveats about persistent disease, but if you look at the less than subtotal group, it's about a six-fold odds ratio of having a persistent disease. So 6 times increase in the incidence of persistent disease in the less than subtotal group. Temporary hypercalcemia varies according to the number of glands that we're removing, and imaging didn't seem to be affected the temporary hypercalcemia rate, but I think that's probably because if we're doing imaging, then they tend to maybe be doing more lesser resections, and when imaging wasn't done, we were doing more totals or subtotals. Then we looked at subtotal versus total parathyroidectomy to see if one of them performed better, and there doesn't seem to be a difference in the persistent disease between those two operations, but the temporary hypercalcemia incidence was higher in the or lower, sorry, in the subtotal parathyroidectomy group, with an odds ratio of 0.63. Sorry, there's an awful lot of data, and I don't want to. I think it's quite a lot to fit in a quarter of an hour, but I apologise for that. So I think in conclusion, we can say that there are very low numbers of these done per surgeon, 1 to 2 per year. The incidence, sorry, I missed out a slide, but we seem to peak about 10 years ago in terms of the number of cases we did per year, and it seems to have fallen since then, presumably as Cinecausa has come in. And the risks of complications, reoperation for bleeding, readmission, length of stay are all reasonable, and not excessive. if we're doing anything other than a total or a subtotal parathyroidectomy, we seem to have a very high incidence of persistent disease, but we've got some caveats around persistent disease in UK Rets. And unless we're removing 3.5 or 4 glands, then we have a high incidence of persistent disease. If we look at our results for temporary hypocalcemia, they are very high compared to worldwide literature, where I think the incidence is less than 20% often. I don't know why we have such a high incidence. Maybe it's our definition of hypocalcemia, but that's interesting. We couldn't see that imaging affected our persistent disease rate, so whether it's worth spending the money on imaging is not clear. Certainly, it might find a few ectopic glands in the mediastinum in a small proportion of patients where neck explorations would be and wouldn't be unnecessary, but whether it's worth spending all that money to find those very small number of cases, it's not sure. And subtotal parathyroidectomy seemed to improve the temporary hypocalcemia. So yes, we haven't had this published because each time we send it to the World Journal of Surgery, and now we sent it to the surgeon, we sent it to the British Journal of Renal Medicine. Each one, I'm afraid, hasn't accepted it. I think there's too much problems with the data, really around the definitions, the way we collect the data in UK Rets could be improved quite easily, I think, by improving that renal stem, and then we would know what we're actually analysing. These definitions have limitations even in primary hyperparathyroidism, and I think their limitations become much more manifold when you apply them to renal disease. Is our definition of subtotal 3.5 gram parathyroidectomy out of date now? I'm not sure. We can improve that, but that's worth discussion. And I haven't mentioned auto-transplantation because we don't record that in UK Rets at all. So that's another issue. And we don't have any long-term data. So we can't tell you if those subtotal parathyroidectomies went on to have further problems with recurrent disease in the future. So that's where we are. We've still got a lot of work if we want to get it published. My suggestion really to get it republished is dropping persistent disease from any further analysis and probably just restricting the analysis to the tertiary hyperparathyroidism group, because actually persistent disease, as per UK Rets definition, is useful in that group. And I think there's a bit of work we could do on UK Rets to improve things in the future, including calciometrics, I think, as well, because we don't include data on whether patients are on that or not. That's me, I think that's me.
Thank you very much. Thanks, Seb. That's some interesting data from UK Rets for the last 20 years. Going to move on, going to do some questions possibly at the end of the webinar, but we're going to move on to Professor Wilkie, Martin Wilkie, who's a nephrologist in Sheffield. Going to really talk about kind of indications for surgery, medical management of renal hyperparathyroidism, and what a nephrologist needs from the parathyroid surgeon. Thanks, Martin. Yep, that's working well.
That's a good idea. Now you can hear me, and you can see my screen. Can you?
Oh no, it's gone now. She's got me.
Oh, it's there now. Right, fine. Okay,
thanks.
Good. All right. So I really enjoyed that talk actually, because it sort of gives a perspective. So you can see that my computer's doing something. We'll just ignore that. So what does a nephrologist need from a parathyroid surgeon? Well, we need you. That's what we need. I'll talk a bit about indications, really. That's the main thing. This is just a bit of, physiology slide that is old, really old. But the reason for showing it is just to talk about the dynamic nature of the renal situation. And it is dynamic. And that's one of the challenges that we have. So kidneys getting smaller with chronic kidney disease, reduction in active vitamin D, of course, and that being a stimulant to PTH, phosphate retention, and then hypocalcemia. phosphate retention is really important. I'm really struck by Slatopolsky's dogs. There's some really interesting papers from the 70s of Slatopolsky doing sort of 5, 6 nephrectomies in dogs. And if you restrict phosphate, the PTH doesn't go up at all. So phosphate is important. We're just not very good at controlling it, and I'll talk a little bit about that as we go through. So next slide, then this is another industry type slide or something, but it just talks about the spectrum of the condition that we're looking at, which is really very complicated, to be honest. You've got the the glands becoming more hyperplastic with time. We've got the relationship between phosphate and hazard of death, and that's a big challenge. In fact, that's been replicated recently in PD from the peritoneal dialysis outcomes and practice pattern study. So guidance says to normalize phosphate in dialysis patients, but it's extremely difficult to do so. And I might as well just tell you why. Clearing phosphate in dialysis is very difficult. We don't clear it adequately. We don't do enough dialysis to do that. And then the oral phosphate binders are difficult to take, and people need to take lots of them. And so, it's very difficult to control this, really. We work very hard at it, but I'll show you some examples in a minute. Also, there's really interesting data about phosphate restriction and mortality. Actually, if you sort of develop mouse models where you reduce phosphate clearance, they die younger, they develop progeria. All that phosphate we get given to us in fizzy drinks and everything else is just aging us and trying to kill us, because it basically increases vascular calcification and all sorts of bad things, mediated via various physiological mechanisms, including FGF23 and so on. Top right, we've got one of the slides about calcification. That's coronary artery calcification, but any vessel that calcifies correlates very badly with outcome. So that's an important marker. So we're working very hard to avoid calcifying blood vessels. And indeed, when I first started at the London Hospital in the 80s with John Cunningham, Professor Sir, he was teaching us that we ought to try and keep calcium at the upper limit of the normal range to suppress PTH. But of course, now that's a bad thing to do. We want to try and keep our calciums lower, but it makes it more difficult to suppress PTH when we do that, of course, because PTH is very sensitive to ambient calcium. Then there's the bone disease, which is a complex situation as well. I mean, we see much less bone disease than we used to, but we used to see lots of bad renal bone disease with the sort of, peripheral phalanges being lost with distal clavicles, the rugged Jersey spine, and the brown tumors, all sorts of other stuff. And then, of course, this is calciphylaxis, which we absolutely hate, and we still see it, and it's still fatal quite commonly when we see it, very hard to control. And that's probably calcification at the microvascular level. And that may be an indication for urgent parathyroidectomy, although many of these patients are actually very comorbid with really advanced heart trouble and multiple other things going on. I've seen them survive, where we've managed to get them home on home hemodialysis and get their phosphates normalized, but it's a very painful and really, really demoralizing condition. There is a registry of that, but we don't have many good interventions for that condition, unfortunately. So this is a sort of the physiological statement, PTH ought to be maintained in a situation that's compatible with normal physiology. And of course, the descriptions about what level that is have changed a lot. We used to have in the old days of picograms, 150 to 300, and that was considered to be inappropriate. Now we're sort of trying to keep it, within, several multiples of normal. Actually, the PTH assay is very fickle and very variable, and we learned that from cinacalcet. If you take a dose of cinacalcet, the PTH falls and then comes up again towards the end of the sort of dosing interval. So it's very variable. So it depends what time of day you measure it and all sorts of other things. And indeed, when we submitted the paper I'm going to show you at the end, we had a lot of argument with reviewers about PTH assays. I'm relieved to hear that you've not had that argument, but anyway. So that's that. So these are the latest guidelines from the UK Kidney Association. And I've just put some comments in there just to help us think about what we try to do in nephrology. So where we've got persistently elevated PTH or rising PTH, we try to do what we can about it. And that includes trying to do something about phosphate, treat, of course, native vitamin D deficiency, which we're good at doing now, and then possibly also introducing some alpha-calcitriol or calcitriol, so active vitamin D. That's the first step. Of course, there's concerns about active vitamin D because of the history of inducing hypercalcemia and a long history of iatrogenic disease as a consequence of that. So we have to be cautious about that, but it's an approach that works reasonably well. And then, of course, calcium mimetics. And I was very excited when calcium mimetics first came in, and we got involved in some of the early studies with them. But they've not actually, they've helped a lot, but they've not solved the problem. And then finally, we get to a situation where we need your help. Quite commonly, that's because we're saying we can't really get this person transplanted because their PTH is so high. We'd rather they had the parathyroidectomy before they were transplanted, because you seem to get a GFR drop if you do a parathyroidectomy post-transplantation and so on. Anyway, that's that story. So I'm going to show you, this is from the EVOLVE study, which is a big study, 2,800 patients from many countries, many sites. We were involved as a site. And it was designed to try and look at cardiovascular death, which was, in retrospect, turned out to be a mistake because it didn't show any impact at all. But there, within the supplementary figures, we've got the impact on parathyroidectomy, which was clear. There was a reduction in parathyroidectomy. And of course, since calcium mimetics have been available, the number of parathyroidectomies which we require in the renal population has become less, but we still require them. So here's some cases which I'm just showing you. Here's a young person, and if you look at the sort of serum creatinine bottom right, you can see over time how the progressive kidney disease is happening. And of course, this person presents actually late to us with advanced, relatively advanced chronic kidney disease. And what that means is all of those physiological components have been happening already. Kidney function deteriorates. Eventually, they start dialysis, peritoneal dialysis in this case. At the same time, you can see the rise in PTH and us trying to control it. And I'll just show you the medications that this person has had. You can see the phosphate binders, calcium-free phosphate binders. We've got Fosex, which is calcium acetate. That's a calcium-containing phosphate binder. More calcium acetate of a different method. Cholecalciferol to treat the vitamin D deficiency. Cinacalcet must be there. Cinacalcet's on that list too. So we're trying to use all of those agents to try to control it. And we're ultimately saying we can't control this. And we keep on inducing hypercalcemia as we're trying to suppress uncontrolled PTH. And you can see the levels are really pretty high. At what point should we refer to you? Well, we're saying, because we can't really control it anymore, we want your help. And Saba does this operation, which is really nice. And then we've got some disease, we've got some activity. And I'm very pleased to see some ongoing activity post-operatively, because I think that's really important. Here's another case, very similar, except this lady's maybe got a bit of primary in the mix, because you can see she always was hypercalcemic. And we couldn't do much about that, even as her renal function declined. So she had a bit of primary in the mix. And Saba has come to the rescue, of course, and has taken the parathyroids out for us. And we can now get her on the transplant list, which we couldn't do in this situation. So that's really important too. But here's another much more challenging case, a young man who's not very concordant, who's dialyzing at home, but is very nervous of every intervention. And I've actually referred him to Saba. I'll try and move this thing out of the way. You can see how dreadful the PTH is. And we've tried everything possible. We have tried to dialyze him frequently at home. You can see the alkaline phosphatase, which is a manifestation of his bone disease. And it's very difficult to manage calcium, and phosphate, very difficult to control, with all of the things that we try to do. You can see all the medications that we've been using to try to improve that. So moving on. So those are some cases just to sort of stimulate discussion. In terms of perioperative management, well, we always load patients because we expect hypocalcemia post-operatively, because that indicates to us that there's been, the operation has really taken out some of the, significant amount of parathyroid. And then, of course, we have to be careful to replace it. And the patients who are most difficult to replace are the ones who have the total parathyroidectomies. And we end up with a very sort of, very volatile calcium and magnesium in those patients. But mostly people with subtotals, we get things settled down fairly quickly, but we have to monitor them quite closely. There's a caveat for our trainees always being very careful about the intravenous calcium replacement because of the risk of causing tissue necrosis, which leads to a solicitor's letter almost immediately. So we have to be very careful about that. This is the study that we did with Saba actually in Sheffield. I think it was, how many cases was it? 235. So in those days, there were loads of them happening. The reason why I show you this is patient survival was very strongly influenced by PTH recovery. And basically, these are the ones that had very low PTH. This is in picograms per mil. Their survival was adversely affected. And the reason why is because we're having to give them loads of calcium and calcify their blood vessels, which is no good for them at all. So I think that's me. I've sort of set the scene, if you like. I've probably not really helped, but I think it's probably more in terms of sort of points for discussion, perhaps. I hope that's been all right. I'll just try and see if I can get back to where I'm meant to be in order to discontinue. Stop. Oh, have I stopped sharing now?
You have now, yeah. Thank you very much.
Good.
That's well, yeah, it's lovely. Again, we'll probably do some bits and bobs at the end and questions, but we're going to move on to Professor Palazzo from Imperial, who's going to talk about his approach to renal parathyroid surgery. Thanks, Palazzo.
I hope you can hear me. I'd like to thank you very much, and I'd like to thank Martin for his talk, which there's a great deal of overlap, and I'm quite pleased there's overlap because the title of the talk is my approach, but what I'm about to speak to you about is an approach. It's just one way of doing it, and the reason why it's an approach and my approach is because, as we've seen, we don't really have hard data when it comes to the efficacy of parathyroid surgery in renal patients. So I think we've already found out that renal-induced hyperparathyroidism is extremely common in chronic kidney disease patients. And this is a medical disease and it's managed very well by the nephrologists. But occasionally, and previously, as we've heard, there was a time where we were doing a lot of renal parathyroidectomy. We're still doing a not small number, but nothing like we did 10 years ago. And the threshold for surgery is highly variable. It's variable not only between departments, but also between nephrologists within the same department. So if, like at Imperial, where in the hub and spoke model, there are 25 or more nephrologists, not everybody refers at the same threshold level. So we have historically used the KDOQI and KDIGO guidelines to guide us towards who shouldn't and who should have parathyroid surgery. And broadly speaking, we get asked to intervene when medical therapy isn't working. And you can break the indications down, from our point of view, into relative and absolute. Absolute are the ones where every nephrologist makes the same decision, and relative are ones where we end up debating it. And we have a very close relationship with our nephrologists because there's a large department. So an open dialogue is really helpful. So we've heard that calciphylaxis, which is essentially the calcium phosphate deposition in the small vessels, subcutaneous vessels, leads to this. Everybody agrees that this is an emergency. And this is the Sunday evening David Tauber telephone call saying, tomorrow you're going to be doing a parathyroidectomy on a patient of ours. It's that sort of level of indication. And anybody that knows, I see that Martin is smiling, so I suspect he knows the personality, and there wasn't a lot of negotiating. If you have brown tumors like this gentleman here, typically mandible and maxilla, with gross facial deformity and alteration of the dentition, this patient needs parathyroid surgery. And again, nobody's going to debate this. And what's incredible is how much of a transformation you can achieve with your parathyroidectomy. It's very satisfying. And you can make the patient actually, who is socially embarrassed, happy to go back into public. And with the help of maxillofacial surgeons, after the improvements have plateaued, they intervene and make things even better. Gross bone loss. Now, what's incredible is how bad this can be. And Martin was saying that we don't see a lot of it, but actually we do in our environment, because a large number of patients are from the developing world. So we have refugees who are coming and they have dreadful disease. They're patients who often can't get out of the chair in the consultation room. Now, what about the relative indication? Well, the relative indications essentially are the skeleton on which we hang our KDIGO type guidelines. In other words, calcium phosphate product greater than 4.1 was something which we used at one point, because above that, we knew that there's a higher risk of calcium phosphate deposition not only in the skin, but also in major vessels and coronary arteries. A PTH of 90, that's picomoles per litre, and that's based on, I think the guideline comes from American units, which is probably picogram per mil. So 90 or 100, if the patient's got a PTH of more than 90, the chance of them having a reversal is not that great. Having said that, today in theatre, we were discussing a patient who was on our waiting list for parathyroidectomy with a PTH of over 100, who appears to have improved dramatically just on medical treatment. Now, in some units, they used the volume of the parathyroid glands on ultrasound. And the idea is that once the parathyroids have reached a certain volume, there's not going to be reversal. And again, this is based on the principle that a patient may have a renal transplant at some point, and therefore they will have a post-transplant hyperparathyroidism, in other words, true tertiary hyperparathyroidism. Now, there's this other issue that some of the nephrologists use, which is the erythropoietin resistance of patients with renal hyperparathyroidism. There appears to be some correlation between tertiary hyperparathyroidism or severe secondary hyperparathyroidism and erythropoietin resistance. And erythropoietin resistance, I understand, I'll stand corrected by Professor Wilkie, is a marker and a predictor of cardiovascular illness and cardiovascular death even. The interesting thing is that I should be listing post-transplant hyperparathyroidism as a relative indication. Now, historically, this was not a relative indication, it was an absolute indication, because you have a precious transplanted kidney and you're running high levels of calcium through it, and that's very undesirable. But the arrival of the calcium mimetics has changed things. Ironically, even though the calcium mimetics don't really help because it makes the patient hypercalciuric. So I've never really understood how we can not operate on a post-transplant hyperparathyroidism. So what are our objectives in renal parathyroid disease? We've heard this largely already. Our objective is really, first of all, to keep our nephrologists happy and do as we're told. But hopefully there's a bit of dialogue in this. And our consideration of success is if we can minimize the long-term effects of the hyperparathyroidism. And how are we going to do this? Well, the idea is to get the parathyroid disease to the point where you render the patient almost normal. So in other words, it depends on the context in these patients. So before you do anything with a patient, you need to understand where they are in their renal disease journey. So if the patient already has a transplant, then we want to render them eucalcemic or normocalcemic and render their parathyroid hormone as normal as possible. But we need to do this in the context of a sick patient. They're often not very well patients, especially the dialysis patients. So we need to look at their anesthetic risk and understand how compliant they're going to be with the medication afterwards. Now, again, a lot of my talk is not with p-values and evidence-based, but my experience is that the patients who are least compliant with the medical treatment are the ones with the worst hyperparathyroidism. And there's nothing to suggest that after a parathyroidectomy, they're suddenly going to become compliant with the medication. I think that this surgery has to be performed in an environment where you have a renal unit and an anesthetic department and an intensive care unit which is functioning, because these patients are not the fittest. So preoperatively, we do not perform localization studies. The only reason we do an ultrasound is to exclude concomitant thyroid disease. We know that by definition, this is multiple gland disease. So you know that you're going to do a 4-gland exploration. The idea of doing 4D CTs, Sestamibi scans, and even choline PETs on these patients, frankly, makes no sense. And I'm very happy to defend that if somebody wants to debate it. The patients their platelets don't work. So they can have 400,000 platelets, but their platelets don't aggregate normally. So the last thing you want to do is give them heparin dialysis. So we use heparin-free dialysis the night before their surgery. So what are the surgical strategies? Well, we can say that essentially there are three. There's the total thyroidectomy, total parathyroidectomy combined with a thymectomy. There's a subtotal parathyroidectomy, and we've heard how the definition of this is not that easy. And then there's the total parathyroidectomy with a heterotropic autotransplantation. So let's just look at these. So the first thing to say is that there is no evidence that there being any difference in morbidity between these three approaches. But when we choose the operation, what we're essentially doing is balancing the risk of early relapse, which you are more likely to get the more parathyroid tissue you leave behind, against the consequences of hypoparathyroidism on bone turnover and therefore the risk of adynamic bone disease. So those are the balances between doing a total parathyroidectomy and a subtotal parathyroidectomy. Now, the advocates that are mainly in mainland Europe who advocate a total parathyroidectomy and autotransplantation use this approach because they feel that it avoids the perils of a neck re-exploration, which has to be done under general anesthetic, which you get if you do a subtotal parathyroidectomy, leaving part of the parathyroid in situ. And the argument is a total parathyroidectomy with autotransplantation means that if you have a recurrence, you re-explore the forearm. And you can do this under local anesthetic. This is a great theory until you've done it yourself. The first thing to say is that if you've ever had to go and fish out parathyroid autotransplants from the brachioradialis, you will know that this is not easy because you have a desmoplastic reaction. You never quite know where the parathyroid tissue begins and where it ends and where it's just scarring. And you're in an unfamiliar territory. And so you're taking more and more muscle away, and you're not really sure when you're going to create morbidity. That's the first problem. But there's another problem which is even bigger, and that is if a patient who's had a so-called total parathyroidectomy with forearm autotransplantation has a recurrence, the most likely scenario is the recurrence is actually in the neck, because not all parathyroids take in the forearm, and the reason you have recurrence is because either you haven't really taken away 4 parathyroid glands, you just think you have, or you have a supernumerary, if not a parathyroid gland, then parathyroid tissue. Most commonly, thyroid rests in the thymus. So you can sense my prejudice against autotransplantation, but you can make a case for a total parathyroidectomy and a subtotal parathyroidectomy. And this is determined by the needs of the patient and the dialogue with your nephrologists. No surgical talk is complete without a couple of pictures. I mean, this is just to show you the problems we have. And the reason I show this is because this is the same patient. And in the same patient, you don't always have parathyroids that look the same. So you can have something, let's see, I don't know if this arrow is showing, which it looks like an almost normal parathyroid gland. And then you have this sort of nodular appearance. This is all one parathyroid gland. And then you can, in the same patient, you can have what looks like a parathyroid adenoma. Now, before somebody says to me, this was just primary disease with a superadded secondary disease, this is a patient with a PTH of more than 100. So this is severe secondary hyperparathyroidism. So what is my surgical strategy? Well, it depends on the patient. If the patient is pre-transplant, in other words, they are likely to have a transplant, what we want to do is we want to leave them some parathyroid tissue. So these patients, I would consider a success if we can give them a parathyroid hormone level which is within the normal range, or certainly less than 10 picomoles per liter, and obviously with normal calcium. That's a pre-transplant patient. Post-transplant, we want to treat them like a primary hyperparathyroidism. In other words, we want to render them normocalcemic and with a normal parathyroid hormone level, because then you have really achieved your objective. In other words, giving them a normal physiology. And if they have a functioning kidney, in theory at least, and you've just left minimal parathyroid tissue behind, these patients do very well. If you're dealing with a patient who is never likely to get a kidney transplant, because they've got a malignancy, because they don't want a transplant, or because they're unlikely to get a donor for whatever reason, then they should have a total parathyroidectomy and a thymectomy. And the rationale for this is simple. If you don't do this, the patient will have a recurrence, guaranteed. Now, the thing to remember is that it's interesting that Seb said that the morbidity was not that bad. The morbidity in renal parathyroidectomy is much higher. And this is our own data, by the way, he had cited. It's much higher than in primary hyperparathyroidism. I know we're not comparing like with like, but these patients are sicker. The operation lasts a bit longer. You have to find 4 glands. If you can't, you can't, but that's the objective. You can't bail out and easily, because you won't have achieved what you set out to achieve, and then you'd be going back into a scarred neck. I mean, to give you an idea, I've had one patient who died on the day of surgery pre-op. So these are sick patients. These are sick patients. Maybe it was the fear of coming under my knife. So that is my prejudice, bias, and anecdotes, which guides renal parathyroid surgery. And I'm very, like I said, I think this is a great forum for debate, which we're probably going to have a bit later. So thank you very much.
Great, many thanks, Pastor. That's really great talk. There's a Q&A in the box there for the people attending the webinar. If you please fire away questions, and we're going to have some questions Q&A at the end of the next talk. So we're going to go on to Prof. Balasubramaniam Sabha, who's going to talk about some case-based discussions. Thanks, Sabha.
Thank you, Sid. Can you hear me?
Yeah, all good.
Great. So thank you. Mine is a very simple task. Go through a case very briefly. I think we should spend more time on questions and questions from you and my questions for the panel. And hopefully there'll be a few minutes for some more questions at the end. So before I start with the case, it's a very simple, straightforward case. Nothing fancy, no tricks or anything. But before I move to the case, could I please ask the audience to answer this question? So you just have to point your mobile phone at the QR code and just answer the question for us, please. There's 2 people have got it. I'm going to give it a minute just so we understand the audience a bit better, and that'll help the panelists with the questions as well. I'm going to give this half a minute, Sid, if that's okay.
Yeah, just for the audience, just the QR code at the top left, if you can go on to that and answer the questions. Thanks.
And then in the meantime, if you wanted to take a question or 2, feel free to, Sid. So that way we can combine this with the questioning.
Yeah, no, there's a question on the forum saying from an anonymous attendee. What are your thoughts on ectopic abnormal glands in the chest? Don't you think it's imperative to obtain some form of uptake scan? These patients are in the best form. Going back again with surgery won't benefit your thoughts. So I think it was a question related to imaging. I think possibly on Fausto's previous talk on ectopic glands, missing ectopic glands.
Yeah, should we ask Fausto?
Yeah, what your thoughts are.
Okay, the first thing to say is, as Seth alluded to previously, you can image these patients if you wish. It's, broadly speaking, not contributory, because the only thing you may pick up are supernumerary ectopic parathyroid glands, most typically, as you say, in the chest, but you're going to do a thymectomy anyway, so usually. So generally speaking, you will pick those up. So the yield is low. Now, if you in a publicly funded healthcare system, we have to have some degree of consciousness about where we spend our money, and I think that it's not a good return to do sestamibi 4D or any other form of imaging other than an ultrasound. A second thing I'd say is that if you do have parathyroid tissue in the chest, it's not such an issue. You aren't going to do a sternotomy right from the outset anyway. And you would most typically want to do the neck operation and then see where you are. You may just find that that tiny bit of parathyroid tissue in the thymus that maybe you didn't fish out is giving that patient just the right amount of PTH to keep them normal after, let's say, a total parathyroidectomy. So imaging doesn't make sense.
Right. Thanks.
That's great. That's great. Thank you. So let's then, so in the previous slide, you'd have seen that the vast majority of us do less than 5 per annum. And then there's a very small proportion, 15% of 34. You know, that's probably 4 or 5 people doing a bit more than that. Okay, so let's just consider a young female, late 20s, end-stage renal disease, started PD 2 years ago, very high PTH levels on multiple occasions. She's on phosphate binders, vitamin D, alpha-calcidol, cinacalcid, everything that Martin's previously mentioned. She's on an active renal transplant list, and you're seeing her in the clinic for parathyroid surgery referred by one of your nephrology colleagues. So my question, and this is to the panel, and just wondering if I could start with you, Martin. So the first question is, how does being on an active list affect the decision to do a parathyroidectomy? Because on one hand, you hear from some of you and the transplant surgeons saying you don't really want a new kidney to be affected by very high PTH levels, and they could become hypercalcemic and therefore hypercalciuric. On the other hand, I also hear the argument that well, maybe the transplant would take out all the stimuli and they're all settled down, and within a year, the vast majority should be okay. So, so how would you sort of address that, please?
Yeah, it's difficult to predict. I mean, some of them will settle. I think if they've had very uncontrolled disease, which has been around for a decent stretch of time, they're less likely to. And you don't really want to be in the position where you're doing a parathyroidectomy, a few weeks or months after the transplant. I think that's the wrong order, really. So we would much prefer that the parathyroidectomy was done before. And sometimes, in fact, people are sort of held off the transplant register until they've had their parathyroidectomy for that particular reason. But I don't know what other people think about that. It's a conundrum, but I think it is better to have the parathyroidectomy done first, if possible.
Okay. Anyone else wants to come in on that? Fausto.
No, I totally agree. I was just wondering what Martin thinks about PTHs that are that high. I mean, they are commoner in the peritoneal dialysis patients. I find the PTH control isn't as good as dialysis patients. But if you have a PTH of 200, I don't know what the statistics are in getting the patient with a PTH, let's say in single digits. What hope is that is there post-transplant?
Yeah, I mean, I think that's right. I mean, that is pretty severe disease. This is probably one of my patients, so it's my fault, I expect. But actually, I find I don't think the assay is particularly, well, once it gets high, it just wobbles around like mad, really. So I think once we get high, we're saying, well, we need, we can't control this medically, and it needs surgery to do so. And I think, again, the chances of that being controlled by the transplant are pretty unlikely. So I think that needs to be done. I mean, this is a physiological situation normally, but it's just, it's stepped outside the normal regulatory mechanisms, really, as it becomes more and more autonomous. I suppose the key is trying to work out whether you think it's autonomous, whether it's going to respond to the transplant milieu where everything's normalized again. And the only marker we've got of that, I think, is just the severity of the elevation of the PTH, probably. I mean, I suppose we tend to sort of try to use medical therapy as much as we can. And the trouble is with the drugs like cinacalcid, often you start it and increase the dose, but it turns out that people aren't tolerating it, not managing to take it very much, and so on. So you have some success and then it rebounds and so on. So it's a bit of a dynamic situation, I suppose. It's a kind of a moving target in a way, really. But once it's clear that we're not getting under control, then it really is time for help, I think.
Okay, that's great, lovely. I'll skip the second question because that's been covered in the talks in terms of other factors and other indications for surgery apart from a very high PTH level. And this is a nice picture I thought I should show. So there was this lady, I don't know if you remember this lady, Martin, from a few years ago, who was presenting to A&E with quite severe left elbow pain. And one of the x-rays that was done before her pathorectomy is shown on the left-hand side of the screen with a big calcium blob in the soft tissues. And this is 3 months before, and she had a subtotal pathorectomy, and 3 months after, and that just completely resolved. And prior to seeing this patient, I always used to think that calciphylaxis is, obvious externally with the skin being affected, but the amount of pain and elbow problems this lady had was quite revealing to me, and how much of a difference this can make. But sometimes my question is, on the other hand, you do an operation and then they become severely hypercalcemic, and the phosphate's still high, and then they can get calciphylaxis, can't they? So sometimes parathyroidectomy can precipitate this problem, right?
I'm afraid my computer's going to restart. I apologize. I'll disappear and come back. I'm sorry about that. It's just a...
No, that's fine. It's fine.
Sorry about that.
So anyone on the panel has had that problem in terms of calciphylaxis being precipitated by a parathyroidectomy for severe renal HPT?
No, I've not encountered it after a parathyroidectomy.
Okay. Okay, that's good. So it's a shame Martin has gone, but hopefully he'll come back. So this lady was keen for surgery. We discussed the pros and cons, and I was wondering if Seb or Sheila or Sid wanted to comment on general principles and thoughts, particularly on laryngoscopy, dialysis, should be pretty obvious, and active vitamin D loading, like Martin said, in terms of your practice, because I'm sure practice is probably quite variable here.
I think we'd
Seb?
like laryngoscopy and bilateral neck exploration. That would be ideal, I think. And it sounded like we need to load them with vitamin D to sort of cushion the post-operative hypercalcemia a bit. So that might be helpful from that point of view. And then imaging, yeah, I agree. I don't think it's necessary. Seems like it's done, though, in about a quarter of cases in the UK RETs.
On the database, yeah.
Yeah, Saba, we have a similar thing to Seb, as in we'd normally get the renal team's advice on when they want to dialyse them. We have a loading protocol so that they're preloaded, and we'll do an ultrasound of the neck. Okay,
that's great. Thank you. I mean, well, I tend not to do an ultrasound. We just examine the patient. If there's no big goiter, then I don't do it. But and I would do an ultrasound pre-incision on table. And currently, we are not doing laryngoscopy if the voice is normal and VHI-10 is normal, but that's something to think about. Okay, so I'll just ask people this question, the audience: what preoperative neck imaging would you organize for this lady? You've heard what the panelists have said, but it'd be nice to know what happens, what do you guys do in your practice? I know there's at least 30, 35 people that are doing parathyroid surgery on this call. Give it a few seconds. To summarize what has been said, I think Foster and Sheila said they do an ultrasound, and Seb said that the BATS audit shows that 75% do not have any imaging. Give it a few more seconds. So quite a few people doing maybe plus minus ultrasound routinely. Okay, that's useful. That's useful. I think we will move on. So with the delays that we have in our system, this lady unfortunately was waiting forever. We arranged a pre-assessment some 8 months down the line after we'd seen her in the clinic. PTH dropped significantly, and she's otherwise well. And she says, well, I actually started taking my medications a bit more regularly now over the last few weeks. So I was hoping Martin would be here, but what would you do? So the cinacalcet, apparently she's a bit more compliant with this. Would you just take it out, given that she's young and the levels have been really high and you want to get this sorted? Or would you go with, continue with the cinacalcet, improve your compliance, and let's see what happens?
So
It's a
hi.
bit of a difficult one, nuanced, surely, but we have this
I think
situation.
Martin's back on, actually. He's on there.
Ah, lovely.
Device, but the camera's not working. But anyway, so the question is, we refer somebody to you, but then miraculously their PTH gets a bit better.
Yeah.
But it's not hugely better. And if we look back, you'll see it's been going up and down like mad. And sometimes we've got a bit better control, but mostly we haven't. So I would say that you've just got her on a good day, probably, and overall the situation is more significant than that. So I would sort of be encouraging you to continue. Is what I would be doing, but others will have different views, I'm sure.
Any other thoughts? I've got one eye on the clock. Any other thoughts? No, then okay. So we'll ask people again what their usual strategy would be for a first-time operation for renal hyperparathyroidism. So you've heard what the panelists would do, or you've heard what the database shows, and you heard Foster's views. But what do you currently do in terms of extent of resection, subtotal versus total, with or without autotransplant? And while we're waiting for people's responses, I was going to ask Martin whether there is any rationale in trying to tailor the operation based on the patient. I mean, would you want us to consider a 75-year-old with on dialysis who has no hope or limited hope of getting a transplant versus a 25-year-old who might get a transplant in the next year, in terms of how extensive the surgeon should be, how low the PTH you would want us to bring down?
Yeah, so I've got a couple of thoughts on that. First of all, I would be unlikely to refer you a very highly comorbid elderly person. I'll be hoping to manage it medically, but clearly if we'd really not got control and we had a serious issue, then we would need your help, of course. In terms of this question of total versus subtotal, and I have every respect for what Fausto said there, but my experience is that the people who've had total parathyroidectomies have gone on to be the most difficult to manage post-operatively in the longer term. And we've really had difficulty maintaining the calcium, and it tends to be very volatile, as I mentioned in my talk. The people who we tend to have the most problems with are the youngsters who are of low comorbidity. And the reason for that is they tend to be kidney patients for many years. They're going to be around for a long, long time. And so this problem ebbs and flows. You know, you do your subtotal and then the disease comes back again. I would kind of prefer that they had some PTH around rather than none. So that's my kind of bias, really. I always prefer they've got a little bit of parathyroid hormone around if possible. So that's my kind of bias. So I suppose, I don't know if that helps.
Yeah, very much. Yeah, thank you. Any other comments? I think Foster, you also do a subtotal or occasionally. Do you want to come back on that?
Yes, I do. So my patients pre-transplant, they get a subtotal parathyroidectomy, usually with a thymectomy, unless it's the inferior gland or part of the inferior gland that I've left behind. Because if I do a thymectomy in those patients, I could devascularize the inferior parathyroid. But if I come back to you, Martin, of your patients, or maybe I should put it this way, of my patients who have a total parathyroidectomy because they're never going to get a transplant, it's not very common that their PTH is 0 after a total parathyroidectomy.
Yeah, and that's fine. I'm happy with that. I'm happy with that. I mean, in our experience, the people who've got very low PTHs are the most difficult ones to manage. But if they've got a bit of PTH from somewhere, then I'm perfectly happy with that. And furthermore, over time, that will probably become a little bit more hyperplastic as the disease continues, because it keeps on going, doesn't it, really?
Yeah.
But yeah, that's an important point. Thank you.
Okay, I think I'm coming to the end of this scenario. So we operate and we find 3 large parathyroid glands, the 4th is missing, the thymic horns have been mobilized, nothing is found. So what would you do now? This is for the surgeons. And please, can you round off your response with a comment on the various interruptive aids? Maybe a couple of surgeons, and then we can bring this to a close. Foster, do you want to start? And then, please.
So this this scenario, near infrared autofluorescence, I do not use. I don't think it adds value in this scenario. Our findings have been that autofluorescence, these glands don't autofluoresce as well as normal parathyroid glands. So, and it also, the penetrance is very low. So in other words, you're not going to identify something you can't see. The other thing to say is a lot of what happens depends on what the other parathyroid glands look like. So if you've taken out 3 Kalamata olives, you know that the chances are, even though they're not homogeneous, the chances are the 4th gland's also quite significant in size. So if you can't see it, then the chances are it's not in the neck. I don't use interrupted PTH because I don't think it adds any value, because my problem is not finding the 4th gland. So the interrupted PTH will just tell me what I know already, that I can't find the gland. Frozen section is of no relevance either, because I need something to remove. I need to find that 4th gland to send it off. So essentially, this is why parathyroid surgery is still fascinating, because it's still a surgical conundrum. The tools and the technology don't help that much. Sorry about that.
No, it's good. It's good. Just reinforces what I would do. Any other comments on that? No? Okay. So that's great. That's great. We'll wrap it up and answer any other questions that you might have, Sid.
Yeah, great. Thank you very much. It's a really great webinar. We're getting good feedback already. There's a couple of questions on line there. Just start off actually. It's interesting, Seb's talk at the beginning, where the UK RET state over 20 years, so nearly 1,500 procedures. Actually, over half of them have had 4 glands removed. So, do you think that's more historical thing? Is that, you know, subtotal parathyroidectomy has changed or become more common as time has gone on? What do people feel? Why are there so many people having 4 glands removed, if we're saying actually that's not the ideal today?
It probably is, isn't it? I didn't actually look specifically at that. That's something I could look at, but I mean, my predecessor in Aberdeen would always do a total parathyroidectomy, I'm told. So I think that's changed over the years. And, you know, I would do the same. You know, I would do a subtotal in somebody who's going to go on and have a transplant, and do a total in somebody who's not going to have a transplant in the long term. So I'd be selective. Yeah, pretty much equal numbers of both. But I could look at historically, you know, which one's in decline and which one's not.
Okay, great. And there's a few other questions here. Yeah,
So there's one here.
Go on, Karen.
Well, there's one that's been partially answered, which is an opinion on IOPTH intraoperatively, and I think most of us being in agreement, but people can differ, that intraoperative PTH doesn't really have a role in renal hyperparathyroidism, where you need to find and identify all 4 glands. But there are a couple of questions saying, so I think this one to Saba. Saba, if you're doing a subtotal parathyroidectomy, do you mark the remnant gland if you've taken 3.5 out in case you do need to go back?
Yeah, I tend to put a little proline stitch in a couple of clips on the proline stitch, but I'm not sure how effective that'll be many years down the line. Gone back a few times, and 50% of the time it doesn't help. But you know, it's either moved away a little bit and things like that. So, but I do mark, yeah, if I'm doing a subtotal and leaving a remnant behind.
Okay.
And then also, I guess, Saba, we'll quiz you since you've been quizzing everyone else. If you can't find the 4th gland, would you image then in that situation afterwards?
Yeah, I guess it's down to, yeah, I mean, like Foster said, we'll take 3 glands out and mobilize. If I've mobilized the thymus enough, then I might take that out. And then the question is, you know, is the 4th gland in the chest or is it intrathyroidal? All you can do is wait to see what the PTH does and see if the nephrologists are happy. The nephrologists are happy and they're now going to manage with much lower doses of cinacalcet. Then they don't come back to you. If they do come back to you and you have and the PT is going up to over 100 and you're being asked to do something again, then you do the imaging. For reoperative renal HPT, you certainly do the imaging, review the op notes and do the imaging.
So I've just got another question actually. So Seb, I know you've looked at the data. What was the sense of how many surgeons were actually doing renal parathyroid surgery in the UK from the UK Rets?
Well, I think over 20 years there was 200
Right.
altogether. So 1,500 cases. So what's
Yeah.
that?
It's quite a rare disease. I know.
About
I know Saba, you were
seven
saying
or 8 in their careers or something like that on average, isn't it?
Yeah.
So I think there's a problem. I mean, if these patients tend to be managed, don't they, by renal units, and then would you move patients between renal units to do parathyroidectomies in higher volume centers? I mean, they're very complex patients, aren't they? So it's difficult, isn't it? I'm not quite sure that's the right thing to do either, but certainly
yeah, it's a tricky one.
Lowest volume operations that we do, isn't it?
I mean, that's a tricky one. It's a bit like the pediatric thyroids. We say maybe the high volume thyroid surgeon should do the pediatric thyroids. So maybe the high volume parathyroid surgeon should do the renal parathyroids. I was saying to Sid just before we started that when I was in my last year as a trainee with Barney Harrison, we did 40 renal cases a year. Now I'm doing two or three a year. So, this is in about 16 years. So it shows the efficacy of calcium in one way, I think. Sorry, Alison.
I think we might have a bit of bias in our data because I think there are quite a lot of transplant surgeons that are doing renal parathyroids, and I'm not sure that we are actually gathering all that data. I think we need to know the number of we need to know the number of renal hyperparathyroid ectomies that are going on in the UK, and then have a look and see what percentage of that is on our database. Because I have a feeling that there may be some bias there, in my personal view.
Okay. And just a quick question to Martin, actually, just about the parathyroid levels. So, what kind of parathyroid levels do you tend to prefer, and what would you be happy with post surgery, or even after medical management of hyperparathyroidism? Would you be happy with?
Sure.
So, just hard numbers.
Exactly. As it starts to rise, we're trying to control it. We're trying to control it all the way through, but we're starting to lose control as we sort of get up to 70 or 80 or 90. And if despite everything we're doing, it's going in that direction, then we want your help.
Yeah.
But
so the calcium, the actual calcium, if it's normal or high, it doesn't really matter. It's all about the PTH.
In the renal situation with secondary, rarely, the only time we get a high calcium is usually when we've done it with our alpha calcium or our calcitriol or our calcium acetate or something. So normally, if we cut those down, we can control the calcium unless they've got primary, as a separate issue, or rather they had primary anyway. But then post parathyroidectomy, if we could have a level running about 10 or 20 as fast as I said, I think that would be ideal, really. That would be ideal. And then it starts to gradually rise again because these people are around for a long time, unless they get transplanted, in which case the situation will settle down then.
Yeah, I think if we're going to need to get something meaningful from UK Rets, we're going to have to change the definition of persistent disease, aren't we, to reflect PTH levels, not calcium levels. Also, POSH, POSH is defined as calcium, vitamin D supplements to measure to maintain normal calcemia, isn't it? And I think in renal patients, that definition is pretty useless because they're often on vitamin D supplements, aren't they? And I don't think surgeons follow them up for 6 months anyway. And so, yeah, I think there's a kind of need for UK Rets to be revised and some agreed definitions. Maybe that's a difficult thing to do, but otherwise, I think the data we're collecting can't really be analysed very easily.
Sure. Sheila or Alison, do you got anything else particularly you wanted to add?
No, I think it was a really good webinar, and I think we've had some fantastic speakers.
Yeah, I'd just like to thank the speakers. Thanks everybody for listening. Yeah, just thank you, Steve and Professor Martin Wilkie, Prof. Palazzo and Prof. Ballasundram, and also Sheila and Sid. Just thank you very much for hosting this. Thank you, Sid. We'll
Right.
see you all at the conference. I think that's our next. I don't think we've got another webinar until the conference now.
No.
So we see
Maybe.
everybody in October.
And maybe an adrenal one in September. But
Oh, and an adrenal one in September. Tell
Yeah.
a lie. An
Yeah.
adrenal one in September
Right.
for anyone who'd like to come. Okay,
Great.
thank you, everybody.
Yeah.
And thank you very much to our speakers. Great chat. Thank you.
So, have a good evening. See you. Bye.